Hip dislocations are not common injuries you will see in athletics, but when they occur, they can occur both anteriorly and posteriorly. Anterior hip dislocations are approximately 8 to 15% of all hip dislocations, the mechanism of injury being a blow to the posterior lateral aspect of the hip. Posterior hip dislocations are the other 85%. The mechanism of injury includes the hip being flexed to 90 degrees, which is the weakest hip position, with a longitudinal loading, which displaces the head posterior to the acetabulum. In a hip dislocation, Nailton's line will be disrupted. For an anterior one, the femur will be externally rotated, the hip will be extended and slightly abducted, and you will notice that the person seems to have a slightly lengthened limb. A posterior dislocation will show itself with the femur internally rotated, the hip flexed and slightly adducted, and the person will have a slightly shortened limb as compared to the bilateral limb. Signs and symptom wise, there will be extensive soft tissue trauma, therefore there will be excruciating pain. If the person happens to try to walk, it would result in a dysfunctional gait. Obviously, range of motion, both active and passive, is going to be decreased in all hip movements. We can do some special tests, perhaps if there's maybe a subluxation. For a posterior dislocation, we can do a hip scouring test, which is simply putting a posterior load and rotating the femur internally and externally. For an anterior hip dislocation, we can look to see if the anterior capsule has been damaged, and we do this through a stress test, which is simply forcing the hip into hip extension. During a hip dislocation, we need to check things neurovascularly. For a posterior, we're going to look for the sciatic nerve. The sciatic nerve is located halfway between the greater trochanter of the femur and the ischial tuberosity. So finding those two landmarks, we'll look for that median place, which is where the sciatic nerve will run. The femoral triangle is going to be found looking at the borders of the sartorius, the adductor longus, and the inguinal ligament. The nerve, artery, and vein all come through the femoral ring and can be located in that triangular space. Diagnosis is going to be via X-ray or MRI. Treatment for a hip dislocation is very important. You need to triage and stabilize as well as treat the patient for shock. Complications can occur due to hip dislocation. There is a very high incidence of an acetabular rim fracture that occurs in conjunction with that dislocation. There may be a femoral head fracture. Acetabular labrum tears may be found, and this includes a clicking sensation that creates an internal snapping hip syndrome. There is probably a good chance of a disruption of blood supply to the head of the femur. Remember, you have the ligamentum teres along with the obturator blood vessel that goes to the head of the femur. If there is a disruption, this will lead to an avascular necrosis of the femoral head. Finally, in about 20% of all hip dislocations, that will lead to osteoarthritis.